All right, welcome again, everyone, to today's STI Expert Hour webinar from the California Prevention Training Center here at UCSF. Today's webinar will feature Dr. Kathy Yang, and we will be discussing hot off the presses, new oral gonorrhea treatments. First, I'll introduce myself. Hello, my name is Kelly Johnson. For those of you who don't know me, I'm the medical director for the California Prevention Training Center. I'm going to be going over just a few introductory slides, and then I will introduce a case, and then I'll turn it over to Dr. Yang. So first, just a little bit about the California Prevention Training Center. We are a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the CDC, and we're a member of a larger network of other STD clinical prevention training centers nationally. If you don't know what we do is we provide virtual and in-person trainings, technical assistance, clinical tools, and STI clinical consultation services. Our focus is all about complex STI issues in patient care. And if you want to learn more about us or the network of which we're a part, you can check out the links on the bottom of this slide. One of our resources of which I'm quite proud and which I do want to share with you is called the STD Clinical Consultation Network, or STD-CCN. This is an online platform which our Prevention Training Center manages for our region. You can go to this platform, you can submit your challenging patient care questions around STIs, and one of our subject matter experts will respond to you in 1 to 5 business days, whichever you prefer. And we can do this by phone, by email, or by text. Again, whatever you prefer. On to today's event. So here's our financial disclosure, which states that we have nothing to disclose. And here's our accessibility disclaimer, which basically says what you see on this slide. Our materials are provided for informational purposes only, and we may not fully meet the requirements of the ADA or Section 508. So if you require this content in an alternative format, please reach out to us, and you can see our email on the slide. It's captc@ucsf.edu. Now for CMEs. Here's our CME disclosure stating that today's training is offered at 1.25 CME units, and there is no cost to that. But one thing we get a lot of questions about is how you earn those 1.25 CME units. So you do have to have done a few things. You do have to have registered for this event on the National Network of PTC's site by May 14th at 3 p.m. Pacific. So registration is now closed. You do also have to attend today's event live and in full. We record your attendance as you sign on to Zoom. And unfortunately, we cannot issue CME credit if you're attending just a portion of today's webinar, or if you end up viewing a recording of this webinar after the fact. Third and finally, you do have to complete a post-course survey evaluation, and that is due by May 22nd of 2026. A note on that evaluation survey, it will come to you 24 hours after today's event. You'll get an email notification. That email should come from training@nnptc.org, and it will come to the same email address that you used to register for today's event. To make sure you get that email, please add the email address you see on this slide to your safe and trusted senders list. And if you don't get it, check your spam and junk folders for the notification. Now, if you meet our CME requirements, you'll receive notification of your CME by June 25th. That will have a claim link and instructions to get your certificate through our CME provider, which is the University of Nevada, Reno School of Medicine. The CME notification does come from a different email address. This is us at captc@ucsf.edu. So again, make sure we are also in your safe and trusted senders list, and watch those spam and junk folders if you don't hear from us. The other thing we get questions about is post-course materials. So our slide handout will be available about 2 weeks after the webinar. You'll get a post-course materials notification email, and that will contain the slide handout, the CME reminder handout, and anything else available from today's webinar. Again, that'll come about 2 weeks after the event. You do not need to request these materials, separately. They will just come to you, and they will come from captc@ucsf.edu. Now, I think we're all pretty familiar with Zoom at this point, but just so you know, a few notes for today, some housekeeping things. Q&A will be turned on for you as attendees to submit any questions that you have, but the microphone, video, and chat will be turned off for attendees. If you would like to use the Q&A, just click on that little icon you see in the center of your slide, submit your question, and hit send. You can submit questions anonymously if you'd like to do that. Just check the little anonymous box, and we'll accept questions up until the last 2 minutes of the Q&A section. Your questions will be answered either directly in the Q&A box by me, or I may save them and they may be answered live in our live Q&A session at the end of the webinar. If you have any questions about today's event or any of our offerings at CAPTC, our program manager is Elizabeth Olson, and you can see her email on the slide here. Our primary speaker for today is Dr. Kathy Yang, and I'm very pleased to be able to introduce her. She is a health sciences clinical professor in the Department of Clinical Pharmacy at UCSF in the School of Pharmacy. She's also an infectious diseases clinical pharmacist at UCSF Medical Center, and she specializes in pharmacokinetic and pharmacodynamic optimization of antibiotic treatment of multi-drug resistant bacteria. She's also become, over the last several years, an excellent resource and knowledge expert around STIs. So we are very fortunate to have her here, and I'm looking forward to her insights on these new oral gonorrhea treatments. That's me. I'm also here, Medical Director, California Prevention Training Center. All right. We are going to start with a clinical case. So there's going to be a poll question for you all. So I hope everyone's listening in. So let's say this is actually a real case. This was on an infectious diseases listserv of which I'm a part, along with some other PTC faculty members. So this was a young woman. She lives on the East Coast. She has a history of multiple antibiotic allergies, including a recent hospitalization for a severe reaction called DRESS, as well as anaphylaxis to both penicillin and cephalosporins, including things like ceftriaxone. She recently developed purulent vaginal discharge, was tested for STIs, and was found to have a positive urine test for gonorrhea, and that was a nucleic acid amplification test. She was treated with the alternative treatment for gonorrhea, which is gentamicin intramuscularly ×1 and azithromycin orally at 2 grams, also ×1. Her symptoms improved, and she said that she did not have any more sex after her treatment. But a follow-up NAT 6 weeks later was still positive for gonorrhea. So the question is, and this is in the urine, by the way. So the question is, what would you do next? And if you can go ahead and launch the first poll, that would be great. Let's see if it works. Excellent. All right. So what would you all do? Would you obtain a cervical swab culture? Would you try to get a different gonorrhea NAT going on a different platform? Would you treat her with ertapenem? Or would you think, hey, didn't the FDA recently approve some new oral gonorrhea treatments? Maybe I should look into those. Giving it just a second for folks to think about what you would do. All right, let's go ahead and show the answers if you don't mind. Okay, all right. So 53% of you are thinking, hey, I came to a webinar about oral gonorrhea treatments. I'm going to pick that. So that's the largest proportion of our answers. But we also have people picking all 3 of the other answers. And I'm not sure there is a right answer here. I'll tell you what we ended up recommending on our side at the California Prevention Training Center. We thought maybe it was reasonable to start with a gonorrhea culture and to try to repeat a NAT on a different platform if possible. The thinking was that it would be reassuring if the culture was negative and the alternative NAT was both negative, that maybe that still positive NAT your patient had was just a false positive. But if the culture and/or that alternative NAT turned out to be positive, things that you would do, of course, would be involve public health. This is a possible gonorrhea treatment failure case. But I do think this is a possible situation where you might consider some of those new oral options for urogenital gonorrhea, as many of you were thinking. And with that, I'm going to turn it over to our STI expert for today, Dr. Yang. Stop sharing my slides and over to you.
Hi, everyone. Let me see if I can get myself going here. It's so nice to be here with everyone. Let's see if I can get this going. Oops. Share. How's that? Look good?
Looks good. We're seeing your objectives.
Great. So,
Perfect.
thank you for having me today. So, I'm going to hopefully give you some insight into these new drugs that are really on the launching pad, and sort of talk about the background of how these drugs came to be and what are some considerations we might have when we prescribe these drugs. So we're going to do a little bit of pharmacology and we're going to talk a little bit about the clinical trials and hopefully give you some tips in terms of how you can practically use these drugs. So these are our two new drugs, gepotidacin and zoliflodacin. I think that's how you pronounce it. Um, I will say I had to practice this one a lot, so I'm going to flub it quite a few times over the course of the next hour. So please bear with me. Gepotidacin actually came out with two different versions. There is an indication for uncomplicated UTI. And that came out first in March of 2025. And then following in December, the indication for uncomplicated urogenital gonorrhea came out. Interestingly, exactly the next day after, zoliflodacin came out as well. So gepotidacin so far is already available to order. It's on the shelves in the pharmacy. Because it has two different indications, it is packaged differently. So you have to make sure that you write for the right one. So the 8 tabs per bottle is specific for the gonorrhea indication, and there is a 20 tab per bottle for UTI. Zoliflodacin, even though it's already FDA approved, it's not yet available. And according to the manufacturer, it will not be available until the second half of 2026. So here is the second Zoom poll. And this is just sort of for my curiosity to see if any of you have actually prescribed gepotidacin so far. All right, let's see what people said. No, all right. That's good. That means we haven't had to use it yet. So hopefully I'll give you some insight into how to use this drug in the event that you do need to use it. All right. So of course we can't talk about gonorrhea without talking about some resistance rates and incident rates and things like that. So this is an article that came out in CID last year, and it piqued my interest because the title of the article was basically, gonorrhea rates are going down. And, when you look at that, I was like, oh, that's really exciting. I don't know if it's really going down, but it's the measured amount is going down. But this is just to show you that, over time, as you all know, all the STIs have been sort of creeping up. We do see this dip in 2019, 2020. And that's probably due to a host of different things that included COVID and then MPOX and then differences in reporting. So even though it looks exciting, it's just sort of just a reminder that we have to be really vigilant. And here, of course, are the current guidelines for treatment of gonorrhea. And I put this here because what I want to focus on really in the next 45 minutes or so is really resistance rates, doses, and when we would use one over the other. And you can see that the guidance for gonorrhea between CDC and the European and WHO guidelines, they're different, right? And they're different for the dose of ceftriaxone that is being recommended, as well as whether or not you add azithromycin. And that's really due to resistance rates. And this, I think, is really, really interesting because this is something that will also come into play when we talk about the new agents. So just a couple words about ceftriaxone resistance, because I'm an ID pharmacist, things like MICs and breakpoints and cutoff values are actually very important when I think about antibiotic dosing. And up until 2026, CLSI, which is our Clinical Lab Standards Institute, didn't actually have a true cutoff for ceftriaxone. So the CDC had said an MIC greater than 0.125 represented decreased susceptibility, but there wasn't actually a true printed cutoff value in CLSI until this year. And that number turns out to be 0.12, and which actually now aligns very well with UCAS, which is the European version of CLSI. So the thing about this that is important is that the dose of antibiotic that we choose and the breakpoint that is published, they're all somewhat related. So these breakpoints represent how much drug you can get into the body. So for instance, a 500 milligram dose versus a 1 gram dose, and how much drug is needed to kill the bacteria. So one is pharmacokinetics, which is how much drug gets into the body, and one is how much drug is needed to kill the bacteria, and that's pharmacodynamics. And these breakpoints will tend to change over time. So over the last 25 years or so, it's very uncommon for us to see breakpoints that get better. If anything, we see breakpoints get worse, meaning that the number itself, the MIC value, starts drifting lower. And that's because we find out we need to give more drug to get over the resistance, or the bacteria is just becoming more resistant to the drug. And the last thing is these numbers reflect what we see in the blood, which may or may not always be relevant to the site of infection that we're treating. So for instance, there are different breakpoints for plasma versus urine versus CSF. And for the most part, for Neisseria, these are plasma breakpoints, but we're treating in, of course, urogenital, pharyngeal, or rectal. And so they may not always be not always apply as easily. So this is just to remind you where we sit in terms of ceftriaxone resistance in the US. So the good thing is it's pretty, ceftriaxone resistance in the US is pretty low. So of course, these are not based on a ton of numbers, but compared to other parts of the world, we're actually doing pretty good. So this is why the 500 milligram dose for us, for the most part, is still relevant and okay. And this is okay for even the genital, pharyngeal, and rectal sites of infection. And I know we see less success when we're talking about pharyngeal and rectal. And that has less actually to do with having more resistant isolates, but more so that we can't get as much drug to those sites. And in here you can see by site of infection and gender, again, resistance rates are really low. So that's the main thing I take from this slide. But there are certain populations and certain sites where we have to, it's a little bit more worrisome. So that, of course, is in total contrast to fluoroquinolone resistance. So this is looking at US ciprofloxacin resistance and using the cutoff value of 1 mic per mil. And you can see that, ciprofloxacin resistance is pretty high, and it's pretty high across all sites. So that includes the genital, pharyngeal, and rectal. So this is very problematic. But this becomes relevant when we start talking about the new agents and whether or not they can overcome this ciprofloxacin resistance. And you can see again by site of infection and gender, it's problematic all the way across, regardless of the population and regardless of the site. So just keep this in mind as we start talking about the new drugs. So, I'm a pharmacist, and I always think about things like dose, and I think about things like, toxicity and how much dose we need. And so I think this quote is always what sticks in my head whenever I look at whether or not something is safe to give. And it's by Paracelsus, who was this physician, um, an alchemist from the Renaissance era. He's a Swiss guy from the 1400s. And he came up with this phrase that says the dose makes the poison. And of course, we all know this, right? Anything in big doses is poisonous. You can poison yourself with water if you drink enough of it. But it's very, very important from the perspective of how we use antibiotics because it actually reflects two different things. The dose that makes the poison towards the microbe that we're treating, and the dose that makes the poison to the person, right? So it has both an application to therapeutic efficacy as well as to toxicity. So this is just a PK curve on the left-hand side. And just to reflect the fact that the site of infection matters and how we dose antibiotics matter in terms of whether or not we get enough to the site of infection and how much we have to get there. And different drugs work differently. So if you look at this curve, you have different ones that have peak to MIC ratio. You have ones that say time over MIC, and then you have AUC to MIC. And these are different measures that we use to look at how well antibiotic works. And this is also the measures that are used when CLSI creates their breakpoints. And for gepotidacin, I hope I said that right, the PK/PD parameter that makes sense is this AUC to MIC ratio. So that's looking at this area of the curve over the MIC value, and it's this whole exposure, amount of exposure. And it turns out that needs to be about 40 to 48. And that's different for something like a beta-lactam or ceftriaxone, penicillin, ceftriaxone, any of those drugs, where it doesn't really matter how much over the MIC you get, you just have to be over the MIC. But the longer you are over the MIC, the better. So every antibiotic works a little bit different, and we have to pay attention to that because that makes a difference in terms of how we dose. This also makes a difference because it turns out these measures, again, reflect what we see in blood. And when we're talking about urogenital infections versus pharyngeal infections, that measure, that ratio of 40 to 48, might be different. Or this time over MIC might be different depending on the site. And that's because different sites have different volumes of distribution. You know, the drug has a penetration issue, so it might not get there. Or different sites of infection have different ways that they can protect that site, so they pump out drugs. And in some cases, you have issues with blood flow. So a perfect example would be something like osteomyelitis, where if there's dead bone, you actually can't get drug enough to the site of infection. On the flip side, if it's a site that has too much blood flow or very high blood flow, you could wash drug out very quickly. So these are all things that need to be taken into account when we think about how much to dose. So then how does this apply to these new drugs? So this is now what we have to think about when we're talking about gepotidacin, zoliflodacin, and our fluoroquinolones. So mechanistically, the way these three drugs work is they all work on this enzyme called type 2 topoisomerase. So topoisomerase is this group of enzymes. It includes gyrase and topoisomerase 4, and their entire job is to basically unwind DNA so that it can be replicated. So gyrase relieves the supercoiling, so it relaxes it. And then topoisomerase 4 removes all the tangles and the knots from the bacterial chromosome. It actually will break the double-stranded DNA strand. It will straighten it out, and then it reattaches it together. And so these two enzymes work in tandem to during DNA replication. So fluoroquinolones, gepotidacin, and zoliflodacin, they all work on bacterial type 2 topoisomerases. But the interesting thing about them is they actually all work on different places. So here is a schematic of the DNA, and you can see it has this blue subunit and this brown subunit. And these are the different subunits that are used in DNA replication. You can see the DNA in the middle. So they all bind to topoisomerase 4 and gyrase, and they block DNA replication, but they do that at different subunits. So ciprofloxacin on the left-hand side, you can see it requires two molecules, and it binds gyrase A and par C. Then you have gepotidacin in the middle, and that actually only requires one molecule. It also binds gyrase A and PARC, but it's at a different location than ciprofloxacin. So the likelihood of cross-reactivity or cross-resistance is actually quite low. And then you have zoliflodacin, which again is two molecules, but that one only binds gyrase B. So this is all really important. I know it sounds really geeky, but it's really important because how it targets makes a difference in terms of how it works and how robust and resilient it is to resistance. So over here on the right-hand side, I have this little chart that shows you where each of those drugs target. And the thing that is being touted about gepotidacin is the fact that it is the most balanced of the three antibiotic, meaning that it binds both DNA gyrase as well as topoisomerase 4. Fluoroquinolones and zoliflodacin, in contrast, favor actually DNA gyrase. So in the with regards to fluoroquinolones, when you have fluoroquinolone resistance, you can do that with a single hit to DNA gyrase. But then if you have something like gepotidacin, which requires both, you actually need a hit on both the DNA gyrase as well as topoisomerase 4. So that's why it's considered a more balanced antibiotic and harder to get resistance to. Zoliflodacin does also have a tendency to favor DNA gyrase, but because it's a different DNA gyrase, it's gyrase B and not gyrase A, there is no cross resistance so far. It's at a totally different binding site. So because of this, the great thing is both zoliflodacin and gepotidacin are active against fluoroquinolone-resistant strains. There has not been any broad cross-resistance observed, especially in the phase 3 clinical trials, but it is actually conceivably possible. And part of that is because, especially for gepotidacin, because it uses the same target, same enzyme subunits as fluoroquinolones. If there is already existing fluoroquinolone resistance, it is possible to get gepotidacin resistance, but it's not very common and it needs some very specific hits. There is also some interesting data that suggests that the order of antibiotic may matter. So if you, for instance, are using different antibiotics in a patient because they failed, going zoliflodacin first and then gepotidacin possibly could lead to increased gepotidacin resistance, but these are all in very small numbers, like a strain here or strain there. So there's nothing that is considered broadly cross-resistant. But as with all antibiotics, bacteria are smart and they learn to sort of evade whatever is out there. So it's just something for us to keep in mind. And the beauty, of course, is that all three of these, both of these drugs, zoliflodacin and gepotidacin, are active against ceftriaxone-resistant strains. So moving on to some, bread and butter on gepotidacin. I have this as a snapshot. So this is some snapshots of each drug, and then we're going to go into some detail. These are both gepotidacin and zoliflodacin are first-in-class drugs. So gepotidacin is a first-in-class drug of this triaza-acinaphthalene. I really had to practice to say that. And as I mentioned before, it has two different indications, and the dosing is very different. So for uncomplicated urogenital gonorrhea, it's actually 3 grams orally every 10 to 12 hours for 2 doses. And it comes in 750 milligram tablets. So that's 8 tablets total. From a PK perspective, it has a half-life of about 9 hours. And the main thing that's important about this, it is metabolized through CYP3A4. So you really do have to pay attention to drug-drug interactions. And we're going to talk about that. It's excreted in both urine and feces. And because it has a component that is excreted in urine, there is this warning about avoiding an eGFR less than 30 mils per minute. It doesn't mean that the drug is going to be toxic. It just means, and there's no renal toxicity associated with the drug, but it just means that if you do have a person with lower eGFR, you will get some higher levels. It's unclear if those are significant, but because the clinical trial was done with people who had eGFR greater than 30, this is pretty much what we can say. It can be taken with or without food, but it cannot be taken with either CYP3A4 inhibitors or inducers. And so why 3 grams every 10 to 12 hours for Neisseria compared to the 1,500 milligrams for UTI? And this is really interesting because, again, the dose makes the poison, right? So we needed a high enough dose to get microbial efficacy. And it turns out actually the 1,500 milligram dose, as well as the 3,000 milligram dose, gave you pretty good microbial efficacy when the MIC was less than 1. So it wasn't about microbial efficacy, but it turns out the 1,500 milligram dose and the 3,000 single dose did seem to have an escape resistance phenomena, meaning that there were 3 participants that did end up having resistance, and that was likely due to the low exposure. So it wasn't the failure due to initial microbial efficacy, but there was an escape resistance phenomenon. But at the same time, we have to balance this toxicity part, right? So the main toxicity for this drug is QTC prolongation. And that, of course, is concentration dependent. And there is this adverse event due to acetylcholinesterase inhibition. So we have to get high enough levels to prevent resistance development, but at the same time have low enough levels to try and prevent the QTC prolongation and acetylcholinesterase inhibition. So gepotidacin was studied in this EAGLE-1 study that was published in Lancet last year. I'm sure most of you have seen this study, but just as a quick review, this was a phase 3 multi-center open label active comparator non-inferiority trial. So all of the studies, of course, for antimicrobials tend to be non-inferior studies. They're very, very seldom powered for superiority. And in this study, we have participants who were greater than 12 and at least 45 kilos with clinical suspicion of gonorrhea or a positive lab test. They were given gepotidacin, 2 doses, 10 to 12 hours apart. And it was compared to what was considered the standard of care at the time. So these were, studies that were started in, 2016, 2017, 19, around then. So the guidelines were different then. And the comparator that was used was IM ceftriaxone 500 milligrams plus 1 gram of oral azithromycin, single dose. And the outcome measure was microbial success, meaning culture confirmed eradication between 4 and 8 days with a non-inferiority margin of 10%. So in this study, which was mainly done in Australia, Germany, Mexico, Spain, and the UK, some in the US, they had 628 participants randomized 1-to-1, with 406 in the microbial intent to treat population. The majority of the participants were male, and actually there were only 17 females that were in the microbial intent to treat population. So that's something to take into consideration. Um, there were 71% were men who had sex with men, and most of the participants were white. They did have 20% of the participants with HIV, but they had to have CD4 counts above 200, so not severe immune compromised. And from a microbial perspective, you can see, though, that the success was pretty high for gepotidacin, 92.6% for gepotidacin compared to the standard of ceftriaxone azithromycin at 91.2. Definitely well within the non-inferiority margin with a treatment difference of less than 1%. So that's awesome. So in this study, they also tried to do the analysis to see if it also met the bar for superiority, and it did not. But at least it met the bar for non-inferiority. And interestingly, this drug had a lot of side effects. And you can see here that 74% of the people who took gepotidacin had an adverse event compared to only 33% in the ceftriaxone azithromycin group. So what was really interesting about these side effects is most of these had to do with the acetylcholinesterase inhibition effects. And that includes both the diarrhea, nausea component, as well as the hyperhidrosis, the presyncope, the lacrimation, etc. So these are all adverse events that are likely related to that acetylcholinesterase inhibition. And even though we said that this drug, gepotidacin, has a risk factor, can cause QTc prolongation, that was not seen in this study. But that's also because because this is a clinical trial, all the people who would be at risk for QTc prolongation were excluded out of the trial. So this is a very healthy population of people who had no cardiac risk factors. And the last thing that's interesting about this is these GI side effects, because they are acetylcholinesterase induced, they actually lasted quite a long time. So we typically think of having GI side effects for, the duration you take the drug and maybe, a couple of half-lives afterwards. But for this drug, even though you only took 2 doses 10 hours apart, you can see that the range of side effects lasted pretty broadly. It was a pretty big range. So that's just something to sort of keep in the back of your mind and to consider when you are counseling your patients. And this is just to remind everybody what acetylcholinesterase inhibitor side effects are. So I apologize for the big splotch. I was trying to find a picture of sludge, but they were all very inappropriate and messy. So you have a big splooch there instead. So you have sludge and dumbbells, and these are just our acronyms for us to remember what the acetylcholinesterase inhibition side effects are. And that includes, salivation, sweating, your eyes watering, diarrhea, GI upset being the worst. And then on the cardiac side, you can have things, of course, like bradycardia, and pulmonary, you can have bronchoconstriction. But these are just a couple of mnemonics to help you remember what those are. So then we have zoliflodacin, and this is also a first-in-class drug. It is a spiropyrimidine trione, and the patient population that it can be used in is very similar from an age perspective, although there is a couple of weird nuances. So there is a dose. The dose is the same regardless of your weight, But whether or not you are over 50 or under 50, you have to take it with food or not with food. And this is a drug that comes as a suspension that must be mixed. Um, I can't wait to actually find out if this suspension tastes good or not, because that actually, again, is a big driver in terms of people's preference for drugs. The half-life of this drug is 5.5 to 6.4 hours. And the difference is because of the food. So if you take it with food, the half-life increases, but the drug levels also go up. So I think the reason you're taking this with food in a person that's over 50 kilos is because you want to maximize, your area under a curve. You want to maximize the exposure you can get with a single dose. This drug is also metabolized through the liver, but it has multiple different pathways, including cytochrome P450 as well as non-cytochrome P450. So the drug interaction issue is not as severe. It is excreted in feces, and there is nothing in the package insert about renal avoiding in renal low eGFR. As we mentioned before, it's not going to be available until the second half of 2026. And the main thing with this drug is it does have a significant risk of fetal toxicity and testicular toxicity. So that's really something you have to think about when you are prescribing in anybody who is of childbearing potential. And this cannot be taken with a CYP3A4 inducer. So in this study, they had very similar patient populations, greater than 12 years of age, greater than 35 kilos. The other one was 45. And this one, again, signs and symptoms of uncomplicated gonorrhea, positive lab tests within 14 days. This was a single oral dose of 3 grams times 1, and again compared to ceftriaxone 500 plus azithromycin 1 gram. And it was the same sort of outcome measure, which was microbial cure, which again was the same dates of 4 to 8 days, test of cure at 4 to 8 days. Interestingly, this drug was designed with a non-inferiority margin of 12%, meaning it's slightly wider than the other study. And it's interesting because you never want to see a non-inferiority margin that's wider. You want to see one that's more narrow because that's how you have more confidence that it works. But it was justifiable at the time because there was basically no other drug out there that was being studied, or there's very little options for GC. So that was one of the FDA's reasoning for having the non-inferiority margin at 12%. This was a study that was also phase 3, multi-center randomized, open label, non-inferior. It was done in a totally different part of the world, Belgium, Netherlands, South Africa, Thailand, a little bit in the US again. Participants were randomized in a 2-to-1 ratio. So meaning for every 2 people who got zoliflodacin, 1 person got ceftriaxone azithromycin. Again, predominantly male, 32% men who have sex with men. And in this case, because there was a large percentage of participants who were enrolled from South Africa, there were more Black African American in the study, and because it was in Thailand, more Asians. Again, they did enroll HIV positive with the same criteria of CD4 greater than 200. And what's interesting here is if you look at microbiological cure, you can see that it didn't do as well as the standard of ceftriaxone azithromycin, but it was still within the non-inferiority threshold. So even 5.3%, even though they widened it to 12%, they actually didn't need to. So it still stayed within the 10% margin. But there was a difference of about 5%. So 5% less good compared to ceftriaxone azithromycin. And again, you can see on the bottom that it was also associated with some adverse events, about twice the rate as ceftriaxone azithro. So no treatment emergent adverse effects leading to discontinuation. But remember, these studies were single dose, so you couldn't really have discontinuation. It was just a single dose and you were done. But you can see here that the most common side effect was headache and neutropenia. And what was interesting was Black and men were more likely to experience the neutropenia than any other population. So that's just something to keep in mind in the back of your head. But the main thing about this drug that makes it difficult is the requirement for kind of a lengthy conversation about, embryo fetal toxicity and testicular toxicity. So based on the animal data, there was a signal for a potential for fetal malformation and fetal loss in women who were of women who, so basically this potential for toxicity occurs in women, but also in women who, where the men was taking the drug. So basically you see the toxicity both in women who can take the drug, and the toxicity is also within men. So I said that wrong. I said that badly. Let me try that again. So there is a potential for fetal malformation, but also when the male is the person who is taking the drug. So because of this, because there is a male toxicity associated with it, the recommendation is that you have to avoid use in pregnancy, of course. You have to take a pregnancy test prior to start, and men should be counseled on the potential for testicular toxicity, impairment of male fertility, and men have to use contraception for 3 months after taking this drug. So when I think about this kind of reminds me of during COVID when we had two different drugs for COVID. We had nirmatrelvir ritonavir, and then we had molnupiravir. And nirmatrelvir ritonavir, which was Paxlovid, had all the cytochrome P450 drug interactions, but did not have the reproductive toxicities. Molnupiravir, on the other hand, did, and it was also slightly less effective. I kind of see them as sort of similar, where zoliflodacin is slightly less effective, and it has this reproductive toxicity that you have to worry about. And then gepotidacin is the one that has the cytochrome P450 issues. So I kind of think of those the same for anybody who has prescribed COVID drugs during COVID. So again, the main thing with this drug is that you have to counsel really about the reproductive toxicities and the need for contraception for 3 months after taking this drug in men. So zoliflodacin is unlike gepotidacin, it's a suspension. And in the package insert, it has all of these instructions on how you take this drug. So it comes in this packet that's, a powder packet of medicine, and it actually comes with its own little mixing cup. So you have to pour the packet into the mixing cup, mix with water only. So you can't sprinkle it with food, but you have to mix it with water, no juice, nothing acidic, things like that. To the 60 ml mark, you have to shake it for 60 seconds, and then you drink it. And then you do it again. So you drink it, and then you put another 60 mils of water in it. You rinse it out, and then you drink whatever's left in the cup. There is this thing in the package insert about you have to drink it within 15 minutes of mixing. I don't think that means that the drug is not going to be it's not going to be effective after 15 minutes. It just means that's how they have tested it too. So, use your judgment when it comes to that. After 15 minutes, it's still okay within reason, right? So the last thing I want to show you before we talk about drug interactions is just this head-to-head comparison of gepotidacin and zoliflodacin. So on the blue side, it's the Eagle 1 trial, and on the orange side or the yellow side, we have the zoliflodacin trial. And I just wanted you to see sort of the comparator of how this drug worked for each of the different studies, depending on if you looked at microbial intent to treat, which is just taking one dose and not having, may or may not have a micro test at the end, versus the microevaluable column, which is where you took all the doses and you did have a culture at test of cure. So if you look at the two, you can see that they both perform pretty well when you're talking about urogenital sites. And it's highly variable when you're talking about rectal and pharyngeal. Also, the rectal and pharyngeal were very, very small numbers, so it's really hard to sort of um, get anything too meaningful out of it. It does work. It's not perfect, but neither is ceftriaxone. So that's sort of what I take from that. But you can see from a head-to-head comparison, especially if you look at the microevaluable column, the one on the right-hand side, you can see that both zoliflodacin and gepotidacin were over 95% effective. So that's great news. The last thing is on the bottom, just to show you where these people were coming from. You can see that there was actually quite a lot of resistance in these underlying strains for the urogenital isolates, but it didn't seem to really matter in terms of efficacy. So whether it or not it was Cipro resistant, azithromycin resistant, or tetracycline resistant, the efficacy was still very, very high, over 95%. And you can see, like, for Cipro, the resistance is over 50% for Eagle 1 and 75% for zoliflodacin. And I just thought I would finish with a few slides on drug-drug interactions. So gepotidacin is a really interesting drug because it is both a CYP3A4 substrate and an inhibitor, and it's also a P-glycoprotein inhibitor in the gut. So when you look at the package insert, there is this statement that says gepotidacin should not be used with moderate and strong CYP450 inhibitors. But when you look at the labeling for UTI, it says only strong CYP450 inhibitors are disallowed. But for GC treatment, it's both moderate and strong. And the reason for that is because the gepotidacin dose for GC is double. It's 3,000 milligrams and not 1,500. And it also says to avoid CYP450 inducers, and we're going to talk about why that is. You have to use caution with QTC prolongating drugs. Nothing is ever going to be sort of for the QTC prolonging part, it's not necessarily going to be an X, but it's something to keep in mind depending on your risk of QTC prolongation. And there is this website that I put here, crediblemeds.org. It's a free website, and this website allows you to check the QTC prolonging potential of any med you put in there. So you can put in a med and it will tell you how likely it is to cause QTC prolongation. It's the website that was used when they evaluated QTC prolongation in the Eagle 1 study, and it's used for a lot of different other clinical trials. And again, you have to be cautious with other anticholinesterase inhibitors just in case you get the augmented effect, and in anyone on digoxin. So the digoxin thing is sort of weird. That's not necessarily a CYP3A4 thing, but that's because it's this drug, gepotidacin, is a P-glycoprotein inhibitor. So if you have a patient who is on digoxin, you just have to be a little bit more careful. You may have to decrease the dose of digoxin or monitor a little bit closer for toxicity. So what is the difference between a moderate and strong inducer inhibitor? And so the reason I put this here is because It's actually can be very, very confusing. And strong inducers or inhibitors usually that is like their main route of metabolism. But you can have moderate inhibitors um, because they have multiple different pathways. The way the FDA looks at this is a strong inducer or inhibitor is any drug that if you give them together will give you more than 80% of the change in drug exposure. So the exposure is basically, if you look at this graph on the left-hand side, the area under the curve, which is the area under this curve here, you can see if you have someone with an inhibitor and the curve goes up, compared to without inhibitor. This is a significant, it's like almost over a doubling of the exposure you would get. That would be considered a strong inhibitor. And remember, these side effects, QTC prolongation, is dose and concentration dependent. So that's why this is so important. So how do you know? Um, I went and looked through all of these different drug interaction checkers to see which one was the most up to date so far. Lexicomp, which is a paid subscription, is really the only one so far that has gepotidacin. Medscape, Liverpool, these other ones, they're all free drug interaction checkers, but they don't have that drug listed yet. So for the moment, the only one that has gepotidacin listed is Lexicomp. So for zoliflodacin, this is a little different. So it is only a CYP3A4 substrate. It's not an inhibitor. So that means it's metabolized by CYP3A4, but it itself does not inhibit. But unlike gepotidacin, it is okay to give with inhibitors, but it's not okay to give with inducers. So you're thinking, why is it one drug is okay and one drug is not? And the reason is because zoliflodacin goes through multiple different metabolism pathways. So the overall risk of that level being too high is very low. And the toxicity profile is much better. So gepotidacin, if you get too high levels, you're going to have QTC prolongation. With this drug, it's going to be nausea, maybe a little bit of neutropenia. But the reason you have to avoid inducers because it's only one dose of drug. So if you only give one dose of drug, that one hit is probably enough to get rid of the drug that it won't be enough in your system. So here's my last few slides on just P450 metabolism, just to remind you what it does. So when you take a drug in the gut, you have cytochrome P450 both in your gut and in your liver, and it will metabolize the drug, and that's the red on the bottom, and then some of it will go into your systemic circulation. So that's normal metabolism. When you have P450 inhibition, you have an inhibitor, some type of drug that blocks P450, you'll end up having more of the active drug in your systemic circulation and less metabolism going on. So your drug levels will go up. So the effect of a CYP450 inhibitor is immediate. So as soon as you take the drug, you get that inhibition effect. So what does that mean practically? So because gepotidacin can cause QTC prolongation, it can happen two ways. First, if you administer it with something else that is an inhibitor, you'll get higher gepotidacin levels. So you likely do need some type of washout period with that inhibitor. So if you're taking another drug, that other drug needs to stop a little bit for at least a day or two before you can take the gepotidacin. Or gepotidacin can actually act as the inhibitor itself and make another drug that can cause QT prolongation go up. So there's two ways that that can happen. Zoliflodacin, on the other hand, it's okay to give with a P450 inhibitor because the increased exposure is not that much. And again, we said the safety profile is a little bit better. But when you talk about induction, this is a totally different animal. So induction, after you take a drug that is a P450 inducer, it takes about 2 weeks for that induction effect to take place because you're creating more liver enzymes to to metabolize drug. So then what happens is you have less active drug in the systemic circulation and more drug that becomes metabolized. But what does that mean for either of these two drugs is because it takes so long, it takes 2 weeks to create the inducer effect. And after you get rid of the inducer, it takes about 2 weeks for that induction to wash out. This is not a great drug to give in combination with gepotidacin and zoliflodacin because you would have to wait at least a week or two, probably a couple weeks, for that induction effect to wash away before you can give gepotidacin and zoliflodacin and have enough drug in the system to have it work. So practically, if you have a patient who is on on something like rifampin, these drugs are not going to be useful. And lastly, how much will it cost? So gepotidacin right now, the WAC pricing is $683 for gonorrhea and $1,700 for UTI. It is currently not covered under federal insurance plans like Medicaid, VA, TRICARE, etc. But there are some limited state Medicare plans that will cover it and some commercial plans. So some may need PAs and some may need STEP. Um, so on the Blue Jepo website, there's actually a site that you can search to see if your insurance plan is covered and whether or not it does need a PA and whether or not it requires step therapy. The thing about that website that is difficult is it doesn't specify UTI versus gonorrhea. So the step therapy and the PA may actually apply to UTI and not GC. But for patients who are on commercial insurance, there is this patient assistance plan that you can download this form and it will limit the copay to $30. This only works for commercial plans. It doesn't work for Medicaid, either state or for federal. And zoliflodacin, because it hasn't come out yet, we don't know how much it's going to cost, but it's likely going to be priced close to gepotidacin. And lastly, I just have a couple checklists for you to look at when prescribing. So things you need to think about beforehand. So DDIs for gepotidacin and things you need to counsel on. So for gepotidacin, the second dose is really important because one dose might be enough to cure, but it's the second dose that's going to prevent the resistance. So that second dose is very, very important and to pay attention to your dumbbell side effects. And for zoliflodacin, pregnancy test in people who can become pregnant, and to counsel on fetal toxicity risk, testicular toxicity risk, and male infertility, and to make sure they know to use contraception for 3 months. And with that, I am going to turn it back over to Kelly.
Awesome. Thanks so much, Kathy. That was amazing tour de force, as I knew it would be. Appreciate how detailed you go explaining the rationale behind how doses are selected and all of the things we need to think about in terms of toxicities and side effects with these new drugs. I'm going to take just a moment to share some of the more sort of public healthy components of this whole story. Hopefully you all are seeing my slides now. Let me know if you're not. But I just wanted to again talk about some of the public health recommendations that have come out recently. So this is again is in the last 2 months, really. So the only two that I'm aware of are from New York Department of Health and California DPH. New York's came out first. It was in April. And essentially they're saying that Gepo and or Zoli can be used for patients, but really looking at when there's few or no other options. So this is their direct quote. Zoli or Gepo can be considered in cases of non-susceptible gonorrhea, cases in which standard of care is contraindicated, or when a person has intolerance of, or after appropriate counseling, declines first-line treatment. So the point is that these new medications are really intended to be reserved for people who have few or no other options. And the reason for that has to do with limited safety data, as well as the side effects that Dr. Yang was just teaching us about. First line treatments are unchanged in the New York guidance. They have a nice table that I think just sort of puts this in perspective, kind of a hierarchy. So ceftriaxone's first. If no ceftriaxone, you could use gentamicin with azithromycin or cefixime. And then the alternative regimen is either Zoli or gepotidacin. I will point out that the dose that they included here seems to be the UTI dose. And I just want to remind you again, the package insert dose for gonorrhea is the 3,000 milligrams taken 10 to 12 hours apart. Even more recently, this is very hot off the presses. This was actually just yesterday or the day before. California DPH also released their guidance, which is fundamentally quite similar. That ceftriaxone remains first line, cefixime is the alternative treatment, and that includes using cefixime as the primary option for expedited partner therapy if a partner does not have the ability to come in for care. And then finally, again, similar to New York, to consider Gepo and Zoli for non-pregnant folks with uncomplicated urogenital only gonococcal infection in the event that ceftriaxone and alternative regimens are contraindicated or unavailable. So really thinking of this as a third line option, that you're only turning to Gepo and Zoli when you really don't have other options available. The California DPH also has a really nice table. It's super detailed. So for those of you who want to learn more, check out this recent Dear Colleague letter from the California Department of Public Health. It includes indications, formulation, dosing, common side effects, warnings, and then other rows covering the reproductive toxicity and lactation based on animal data, the different populations that were studied, and the notable study exclusions. With that, I will turn it over to questions. I will thank you all for coming. I'll thank Dr. Yang especially for being here. I'm going to remember to put up the CME slide, and we do have some questions in the chat. So, and I also have some questions if we have time. If not, I may ask you separately. All right, let me just pull up our Q&A. All right, so the first question, which is interesting, which I had not thought about, is for folks who are experiencing some of those sludge or dumbbell side effects, would you treat them with an anticholinergic? That one's for you.
It's a great question. I never thought about that. I would not. And I think part of that is you have to think about what are the actual side effects because the sludge side effects, there's so many of them. If it was diarrhea, you can absolutely treat the diarrhea. But if it's something that is nausea, you could treat the nausea. Just with your normal, medications for diarrhea. But if it's something that is like a cardiac side effect, and some things you can't even treat, like if you have lacrimation, those you would just have to let it run its course. But depending on how severe the diarrhea is, you could try that.
Got it. Thank you. I spoke to this a little bit just now, but our second question is whether these newer medicines, the Gepo and Zoli, would be appropriate for patient-delivered partner therapy, aka expedited partner therapy, um, or will they be compared with cefixime? I'll give the public health perspective first and then see what you think, Kathy. I think the public health perspective is we have a lot more experience, including around safety with cefixime, and especially when you're talking about treating a patient that you're never going to see. I think most of us would still feel more comfortable using cefixime, just given the drug-drug interactions and the side effects and the reproductive toxicity issues with the newer medications. So, favor cefixime. What do you think, Kathy?
I agree.
Great. We're on the same page. All right, next question. For patients with a history of C. diff, did you see anything about, I didn't see anything around this. Did you see anything about C. diff in association with Gepo or Zoli?
I didn't talk about it, but it's a great question. And when I think back about it, it is something that was studied in the study in each of the trials, but I don't remember it being an issue. So I didn't put it on the slide.
Okay, so we think not, but neither of us recall the
Yeah.
details. All right. Okay. All right, and somebody just sharing back to the issue of expedited partner therapy that our partner pack includes azithromycin. Is that the recommendation for gonorrhea partner treatment? So in California, we do recommend cefixime actually as the favored partner delivered patient or patient delivered partner therapy or expedited partner therapy for gonorrhea. So cefixime. Azithromycin 2 grams as monotherapy may or may not work. I think if you're using that, we would generally favor a test of cure to make sure that it worked because we do see resistance to azithromycin in gonorrhea. All right, we have, let me see, a few more minutes and we answered our question. So I'm going to ask one, which came up to me as you were talking, Kathy. Just I'm going to find my question, but I was wondering about whether, I don't think we'll need this very often, but if you did need resistance testing, like if you had a gonococcal isolate and you wanted to know if it was susceptible to Gepo or Zoli, like can we get that? Are any labs doing that?
It's a great question, and I went down this rabbit hole a couple days ago because I looked through all the labs that we would normally do send outs to, and I couldn't find a single one that was doing it so far. None of the commercial labs that I could find had it so far.
I see.
Yeah.
Yeah, I don't know where you'd get this either. And I don't know that we have CLSI breakpoints or anything. Like if there's a number that we'd be going for, you tell me if I'm wrong on that.
Yeah, so it turns out though Hardy does make a testing kit for it.
Hmm,
But I couldn't find any lab that was actually using it.
I
So
see.
you could buy it and do it, but it wouldn't really be a validated test because,
Okay.
anytime you do it yourself, you have to validate it and all that. But they do sell a kit, but there wasn't anyone that I could find that was actually doing it.
Okay, good to know. All right, we've got another audience question now. This is about an uncomplicated UTI, which is actually not so much the topic of our STI webinar, but we'll still ask it. It's in the region. All right, would Gepo be a good option for someone with a UTI resistant to oral antibiotics? This person recently had a patient admitted for vancomycin, so must have been a gram-positive organism. Wonder if oral Gepo could have kept her out of the hospital. Are you thinking about it that way as an option for resistant UTIs?
Yeah, that's a great question. What would you use it, Kelly?
Yes, it's a good question. I mean, it would go back to, I don't know. I don't have any susceptibility
Exactly.
like
We don't have any
options.
susceptibility. Um,
Yeah.
but if it's an option, of course, it's in the toolkit. It also sort of for me would depend on who the person was. Is this,
Mm-mm.
female, is it male, and all that other good stuff that goes along with it.
Hmm.
Because that 5-day is a UTI treatment for women. And as we know, men would require, for males, that might require a different treatment
Mm.
duration. I don't actually know what that would be.
I see.
Yeah.
I don't either. All right,
Depending
we
on
have
the woman.
come. Makes sense. We've come to the end of our webinar. Kathy, thank you so much for being here with us again. Thank you to the audience members for being here. We will send out the post-course materials. You don't have to request them. They'll come to you. And remember what you need to do for CMEs if you want to collect them. Thanks again. See you next time.